So good morning, Jeffrey. Thanks for the very nice introduction. It's a pleasure for me to be here. I'd like to thank David, the organizing committee, and LFSA for the opportunity. So what I want to do in these 20 minutes is give you some more information about the Brazilian story, specifically about R337H and other mutations in Brazil, and focusing specifically in our region, which is southern Brazil. So I have divided the talk in two parts. First, I'm going to talk a little bit about prevalence of germline TP53 mutations in Schomburg families and breast cancer patients in the region. Also, I want to stress again on the differences in phenotype of these carrier families. And then in the second part of the talk, I'm going to present some data on potential cancer predisposing mechanism in the R337H carriers regarding oxidative metabolism and DNA repair deficiencies. So before we start, I just want to remind you again the importance of the problem in southern Brazil. We know nowadays that about 1 in 300 newborns in the region carry R337H. The majority of our patients with Li-Fraumeni-like syndrome carry the founder mutation. This was first shown by Maria Isabel in her paper in 2007. She already mentioned that, but she looked at 45 unrelated Brazilian families with clinical criteria of Li-Fraumeni and Li-Fraumeni-like syndrome. They were recruited from 3 Brazilian states. She identified a germline TP53 mutation in about a third of these patients, and half of them with the mutation carried R337H. Now, when we look at the international prevalence data of germline mutations according to clinical criteria, we will see that the most commonly used criteria, Schomburg, and now more recently modified Schomburg, give us an estimated germline mutation prevalence between 20 and 30%. This is what Maria Isabel has seen, more towards 30%, and we just recently started a study looking more carefully at our southern Brazilian families with Schomburg criteria. These are different from the ones described by Maria Isabel. We looked at 82 families so far. 20 have a germline TP53 mutation, giving us an overall mutation prevalence of 24%, which is again within what is expected when using these criteria. However, 80% of the mutations in these families are R337H, and so proportionally we have much less DNA binding domain mutations. This is strange, especially because in southern Brazil and in Brazil as a whole, our population, although very mixed, is predominantly European in its origin. So one would expect that the DNA binding mutations would be seen at a prevalence that is similar to what is seen in Europe. And it just looks like as if R337H has taken over the family phenotype of Schomburg. Now, when we look at breast cancer, this is a recent study with an amazing size of patients tested with a multi-gene panel, over 35,000 women. This was published in 2017. We just also saw Judy's data. And what these international studies have shown us is that the prevalence of pathogenic variants in breast cancer patients that have a phenotype of hereditary breast cancer, either just breast cancer or breast and ovarian cancer, is around 0.2%. Judy has shown about the same prevalence just a few minutes ago. Now, when we look at Brazilian families that have been tested with multi-gene panels, there's nothing published about this at this point, but I was able to look at two groups of series of patients. One is a series of patients from southern Brazil, 358 probants with the hereditary breast and ovarian cancer phenotype. And when these patients were tested with multi-gene panels, the TP53 mutation prevalence was 1%, 5 times what has been observed internationally so far. And the second series, which is amazing for Brazil, 1,500 patients that were tested at a commercial laboratory in Brazil. These are data from Rodrigo Guindalini. Also patients with hereditary breast and ovarian cancer syndrome. The TP53 mutation prevalence in these breast cancer patients is 1.5%, even higher. Now, if we take his data and just look at the distribution of the 350 pathogenic and likely pathogenic variants observed in these hereditary breast cancer patients, you will see that, as expected, BRCA1 and BRCA2 account for about half of the pathogenic mutations. However, the third most commonly mutant gene is TP53, which is different from everything that we see in other countries. And then, more interestingly, if we look at the specific mutations in TP53, 71% of them are R337H. So again, R337H is really the main culprit here when we talk about TP53 mutations in Brazilian patients, either with Schomburg criteria or with breast cancer. We have just started looking at a series of patients with early onset breast cancer, diagnosed under the age of 50, and who are consecutively recruited from an outpatient breast surgery clinic. So at recruitment, we only look at the histopathologic diagnosis and the age at diagnosis. We don't look at family history. So it's an initially unselected cohort for family history. We then go back and look at the family history. We classify these patients according to the Schomburg criteria. And what we see, interestingly, we have looked at 300 patients so far, is that the frequency of R337H in this unselected group of breast cancer patients diagnosed under the age of 50 is 2.5%. So that means that 1 in every 43 early onset breast cancer patients in southern Brazil is an R337H carrier, which is an amazing mutation frequency. And what is even more important is that although the numbers are still small, the frequency doesn't seem to be different if you have or not Schomburg criteria. And so this tells us that the Schomburg criteria are probably insufficient for identification of carriers of this mutation in Brazil. So we have to find out a broader way of identifying these patients. Now, if we look at phenotype of the families that carry an R337H mutation, this is a phenotype, this is a pedigree, from the original paper from Marie Isabel. It doesn't have a pediatric cancer in any individual, but we see early onset breast cancer, gastric cancer, soft tissue sarcoma. So in many generations, so it's a typical Li-Fraumeni-like phenotype, but then again, we have families like this one. This family is from my clinic. I have followed this family for 12 years now. The proband is a child, now a boy, that has been diagnosed with adrenocortical carcinoma at 1 year of age. He has a sibling who is also a carrier. The mother is a carrier. The grandmother is a carrier. The mother has a half-sister who is a carrier. These are the current ages of the patients, and none of them have developed cancer. So for us as clinicians, this is a counseling nightmare. What am I going to say to this family? Do the same rules and the same screening guidelines, for instance, that we use all the time with families that have classic DNA binding domain mutations, or we have a fully penetrant. Do they apply to families like this? I'm not sure I'm comfortable in offering the yearly resonance protocol with all other tests that involve blood tests every 3 to 6 months to all the carriers of this family. We just don't know how efficient it would be in these very low penetrant families. So the question is, and I'm very happy that we had a comment about this just now about the modifiers. The question is that we have identified several potential modifiers of the phenotype and R337H families. These include variants within TP53 in the coding and non-coding regions, microRNAs, other genes that are part of the P53 pathway. Just yesterday, we saw potential modifiers in other genes with the talks from Jerry Zambetti and Gareth Bond. But we don't really have the opportunity at this point to put all this information together And what would be a dream for us clinicians is have really a tool where we could look at all of these information, the mutation germline, the phenotype modifiers, the risk from the environment, and come up with a real or an approximate estimate for these families of cancer risk. So the conclusions from the first part of my talk are TP53 mutation prevalence in Brazilian Schoenberg families is similar to what has been described worldwide, but most families carry R337H. DNA binding domain mutations are less frequent. Panel testing of hereditary breast cancer patients shows that TP53 mutation is the third most commonly mutated gene. TP53 is the most common mutated gene, and in most cases, the mutation is R337H. Schoenberg criteria are insufficient to identify all R337H positive families. And for the patients that are here, this is a very important affirmation. Brazilian R337H LFS is different, and we have to look at it in a different way. So where do we go from here? There's a lot of work to do, many unanswered questions regarding R337H in Brazil, and these include how frequent is R337H outside the southern and southeastern regions, which have been fairly studied by now. How do we define Brazilian R337H LFS, by genotype, by phenotype, or by both? How can we optimize identification of R337H families? What are the phenotype modifiers in R337H families, and how do they contribute to cancer predisposition? And should surveillance strategies be the same in all families? Among many other questions. These are just the main questions. So I still have a little bit of time, and I want to briefly show you some very exciting results that are actually from the work of my colleague, Gabriel Macedo. Gabriel is a PhD. He did his master's and PhD in our lab. Now he has been hired as an independent researcher and is building his own research group. And Gabriel was interested in looking at oxidative metabolism and DNA repair abnormalities, specifically in the R337H carriers. So his first study was published in 2012. This was a case control study where he looked at oxidative damage in parameters in the blood of carriers of R337H. And in this study, he showed that there was oxidative damage in carriers, both towards lipids and increased oxidative damage towards lipids and protein in carriers. There was also an increased antioxidant content and apparently consumption of ascorbic acid in these individuals. Since this was a small cohort, 17 carriers and 17 controls, he had a question whether this phenotype would be related to cancer, and since some of the carriers and controls had cancers before and others not, he looked at the data stratified by a previous cancer history or no previous cancer history and found no difference. So the first conclusion from this small study was that there was an evidence of increased ROS-induced damage to lipids and plasma in the blood of all R337H carriers, and apparently this was irrespective of their previous cancer history, so something unrelated to the cancer phenotype, something that was there from the baseline. 6 months later, the group from NIH, Wong and collaborators, published in the New England Journal of Medicine a very interesting study that was in line with what we had described, showing increased oxidative phosphorylation of skeletal muscle in LFS patients. But all of them were DNA binding domain mutation carriers. None of them had R337H. So Gabriel then wanted to go on looking at this redox metabolism parameters and also DNA damage responses, and he thought of a different approach, looking at primary fibroblast cultures from our Li-Fraumeni syndrome patients. So we performed skin biopsies and established primary fibroblast cultures from 9 volunteers with 5 different TP53 genotypes. These included 2 patients with DNA binding mutations, which had been affected with cancer before, One patient who was a homozygous for R327H also had been affected with adrenocortical carcinoma in infancy, and 2 carriers of R327H, 1 cancer affected and 1 unaffected, as well as 3 wild-type TP53 cancer unaffected controls. So he first looked at mitochondrial physiology parameters, the baseline in the primary fibroblast cultures. If you look at panel A, there was an increased ROS production, especially in the R327H homozygous carrier. The R327H and DNA binding domain mutation carriers had some increase in ROS production, but this was not statistically significant. He also looked at some antioxidant proteins, GPX1 and SOD2, which are modulated by P53. And here you can see an increase in the expression of GPX1 and SOD2 in the R327H homozygote, especially GPX1 is highly expressed, and a mild increase only in SOD2 in the heterozygote, suggesting that there could be an increased antioxidant response. And finally, in collaboration with another colleague from the university, Fabio Klimt, he looked at mitochondrial oxidative activity by high-resolution respirometry. And here, the only significant difference from controls was observed in the DNA binding domain mutation. There was no significant difference in the R327H carriers. In a collaboration then with Sylvie Sauvego in Grenoble, Gabriel looked at DNA damage responses, and for that he induced the DNA damage after 3 passages in these primary fibroblast cultures by UVB and ionizing radiation, and extracted proteins from these cultures after 24 hours. And these protein extracts were then used in something like a complementation assay. It's a strategy that was established in Dr. Sauvego's lab, a multiplexed enzymatic DNA repair assay on a biochip, where she has included in these biochips common types of DNA lesions, both of the nucleotide excision and base excision repair pathways, the axis spot, and then another biochip that looks just specifically at base excision repair, the glycospot. So these are very preliminary results, but when you look at these graphs, you have to see whatever is in a red and dark red color indicates very high repair activity, and then what is more towards the blue, very low or absent repair activity. Remember, this is 24 hours after the insult. So when we look at UVB damage, you see that the heterozygotes, they behave, one very similar to the control, one has an intermediate behavior, but the homozygote behaves very similar than the DNA binding domain mutation. In the cells that were exposed to ionizing radiation, what you see is that the homozygote has a very, still very active DNA repair 24 hours after the insult, different from the heterozygotes. And these graphs just show how the phenotype of DNA repair response clusters both for the heterozygotes and the homozygotes in relation to the controls. When they used the other biochip for base excision repair, after 24 hours, there was mostly no repair activity detected, except for still a high repair activity towards A-basic sites, especially in the homozygote and the DNA binding domain mutant, both after UVB and ionizing radiation. Here you can see in the upper panel a compiled data from the wild-type cell lines, and on the bottom panel from the mutant cell cultures, showing that really the repair of A-basic sites is much increased still after 24 hours of the lesion. So the conclusions to this part is that a basic hyperoxic state is observed in primary fibroblast cultures of the TP53 mutation carriers analyzed. There is a variable increase in ROS levels and persistent repair of a basic site 24 hours after damage in all mutant fibroblasts analyzed. These are the types of lesions mainly caused by ROS. Oxidative damage is identified in R327H carriers, but the exact mechanism to explain this finding is still unknown, and whether this metabolic phenotype contributes to tumorigenesis in persons with the Li-Fraumeni syndrome remains to be determined. We have just finished 2 weeks ago a small clinical trial. This is a very initial, small numbers of patients where we treated them for 14-day courses of different clinically used ROS scavengers. We obtained samples immediately before and after the treatment. We'll look at several oxidative damage parameters to lipids, proteins, and also inflammatory markers. And the main question that we want to answer at this point is just if we can see a change in the biochemical phenotype of these patients with this very short course of antioxidants. So with this, I'm going to close, and if there's time, I'll be happy to answer any questions. Thank you.
We probably have time for one question, if we have any. Here? Anybody? All right. Well, next one. Oh, go ahead. Carol, previous.
This is more of a comment than a question. That's fascinating about the oxidative damage. I know we already talked about it, but I just want to point out that this series of cells that we generated with both heterozygous and homozygous core domain mutation have a very similar change, very likely in metabolism and ROS and oxidative stress. So there's something very interesting about having these mutations in cell lines, at least.
This is very important that you comment on this and you have independent findings showing this, because for a long time I think people have questioned if R327H is really a pathogenic mutation or not, especially because we have these families with very low penetrance. We don't know if this is the single mechanism, probably not, but it certainly is important, and we should look into that because potentially there's an avenue for treatment in these patients.
Thank you.